I'd like to welcome you all to this Lunch and Learn session on GI complications. My name is Linda Cummings. I'm an associate professor at University Hospitals in Cleveland. I'm a gastroenterologist and I see adult patients. And I finished the CF Foundation Digest program back in 2019. And just a couple of housekeeping items before I introduce my partner in crime here, Kim Altman. We'll be taking questions through the mobile app. And we do have kind of two sections to our talk. In the beginning, we'll be talking about the scope of practice, and we'll check the app for questions at that time.
Hi, everybody. So my name is Kimberly Altman. I am the dietitian at the Adult CF Center at Columbia University Medical Center in New York. But I have also covered peds there, so I'm going to talk a little bit about both peds and adults when it comes to the dietitian's scope of practice in terms of caring for patients with CF. This is our disclosures. So our objectives for today are, we're going to talk about the approach to patient care and the integrated care for gastrointestinal complications for people with CF from the dietitian perspective as well as the gastroenterologist perspective. We're going to talk about an overview of the GI manifestations of cystic fibrosis and then their nutrition-based management. And then we're also going to discuss, like I said, the scope of practice for gastroenterologists and dietitians, as well as the dietitian's assessment of the gastrointestinal manifestations and symptoms, and when we want to refer to a gastroenterologist. The diagram to the right is highlighting the topics that we're going to cover in our talk today. So these are the main things that as a dietitian I would kind of look at as the things that I would focus on in terms of education and topics that I cover with the patients. So for CF diagnosis, the different things that we're going to talk about, it's going to depend on, is it a pediatric diagnosis, a baby diagnosis, or an adult diagnosis. So at diagnosis in an infant or child, you're going to educate the parents on enzymes, on salt supplementation, on vitamins, any change in symptoms to look out for when you need to make adjustments in enzymes. What are the growth goals in terms of pediatrics? I know we have a lot of sessions on the BMI changes, but for right now, you want to make sure that there are growth goals for pediatrics because there's still, issues in terms of that. And for infants and children, you want frequent follow-up. They should really be seen at every visit, and then you probably want to do phone follow-ups between visits because there's a lot of changes happening. And for adult diagnoses, what you're educating them on is really going to depend on their complications. Do they have pancreatic insufficiency or not? Do they have GI complications or not? So what are their goals? What are their GI symptoms? Do they need enzymes? And then in general, the dietitian is responsible for enzyme dosing for the patients as well as educating the patient on the enzyme dosing. And although this is frequently weight-based, you need to often adjust for meals and snacks that are of varying sizes. So if breakfast is half the size of dinner, you don't need to give the same enzyme dose. And this is best done by the dietitian because we're the ones who are typically getting a more detailed diet history. And then also you want to educate the patient and parent on topics that are relevant to them based on whether they are pancreatic insufficient or pancreatic sufficient. And then when it comes to GI symptom management, if a patient has any GI complaints, and sometimes when you say, are you having any diarrhea, are you having any bloating, they may say no and think that because whatever symptoms they're having is quote unquote normal for their CF. Sometimes it's really helpful to use a GI symptom tracker to pull a little bit more information out of them. So the next couple of slides are the GI symptom trackers that are the most updated. There are other ones from other places, but these are the most updated ones. So this is an electronic version that you can use. It has a QR code. You can email this to a patient if you're doing a video visit, or if you want to send it to them prior to your visit and then they can email it to you. This is available from your rep, from wherever, and it's actually really helpful because it does give you a lot more detail on what symptoms are the patients actually having. And it's available for children and adults with pancreatic insufficiency. So this is what the child symptom tracker looks like online. I did not have a PDF copy of this one, but it really goes through a lot of detail about their bowel habits, their abdominal pain, their bloating, and their frequency. So it gives you an idea of, is it really bothersome and is it affecting their quality of life? And then this is the teen and adult GI symptom tracker for pancreatic insufficient patients. And again, the same idea of questions. And again, it focuses on what are their symptoms, how frequent are they, and it also does ask about body image and how they feel about their weight and BMI. And then this is also for patients that are not pancreatic insufficient, because some patients that are pancreatic sufficient do still have GI symptoms, and it's important to understand where are those symptoms coming from, what's causing it, and can we help with managing those symptoms. So now I will pass it on to Dr. Cummings. Linda?
Yeah, so I just wanted to emphasize what Kim was saying about the symptom trackers. We also use them in our center, and I would say they're very informative when I look at them, because oftentimes just reviewing the notes from other members of the care team, I feel that some patients may feel maybe embarrassed to talk about some of these symptoms to some of their other care providers, but I feel that they're maybe a little more honest on the symptom tracker, and sometimes even talking with that patient, I don't get that much of a sense of the severity of a symptom, but the symptom trackers actually ask about the frequency of certain symptoms. So, just gathering more history using the symptom tracker has been very helpful in our center as well. I'll talk about what we've considered the scope of practice for referral to GI. And these ideas here were generated from multiple discussions. We met, the gastroenterologists and dietitians met over a period of meetings. We actually meet on a monthly basis to talk about patients. And we came up with a list of potential reasons that a patient may need to see GI. And we reviewed this with the entire care team during our monthly CF meetings. So this did have some input from other members of the care team. So patients with a new cystic fibrosis diagnosis, I can only focus on what I tend to see at seeing adult patients. I'm not a pediatrician, but I obtain history focused on GI complications that can be linked with cystic fibrosis. So some examples are gastroesophageal reflux disease, gastroparesis, liver disease, and constipation. Obviously, a lot of patients have abdominal pain. With regards to reflux, this could be a little basic for some people in the audience, so I apologize in advance if it's too basic. So I'll ask about heartburn and regurgitation. Regurgitation is the involuntary reflux of gastric contents into the esophagus. Those are the two hallmark symptoms of gastroesophageal reflux disease. For gastroparesis, if we suspect that, I can ask about nausea and vomiting, but I would say that those symptoms are kind of non-specific. And at least in the era before modulators, when patients oftentimes had a chronic cough, I would sometimes have to determine whether or not I thought that their vomiting was from just very severe coughing episodes, which can trigger a lot of nausea, or from something else. Liver disease, so you can ask about any history of abnormal liver tests in the past, any history of jaundice, whether they've ever had ascites. And then for constipation, I'll ask a pretty detailed history. I'll get a sense of how frequent a patient has bowel movements, and ask them about incompletely evacuating bowel movements and difficulty with straining. Also for new diagnoses of CF, I think it's important to determine whether or not a patient is pancreatic sufficient or not. So I'll actually ask about symptoms that could suggest that, such as bloating, abdominal pain, steatorrhea, and previous episodes of pancreatitis. I'll also ask about previous abdominal surgery, previous endoscopic evaluation. So for patients who are transferred to our center who have CF and a history of GI issues, a lot of the first visit oftentimes is doing what one of my colleagues has called a chart biopsy, that is trying to determine what previous evaluation the patient has had, including any specific imaging or labs, previous endoscopic evaluation. So these are some of the conditions listed here: a history of eosinophilic esophagitis and history of liver disease that we thought would warrant specific GI follow-up. Especially now in the era of modulators, which can be associated with hepatotoxicity, I think it's important to screen for what I consider, what I call it occult liver disease. Since liver function tests are a part of the annual labs that you'll get on a patient, you can look back to see if a patient has had abnormal LFTs, and we set a cutoff of up to 2 times the upper limit of normal. Some patients may have had previous abdominal imaging, although it kind of depends on if they've previously had any symptoms to warrant imaging. But if abnormalities showed up in the liver, or if there was an enlarged spleen, these might raise the suspicion for liver disease. We've been talking also about concerning GI symptoms, and we're talking about red flag symptoms. These are reasons that a patient may need referral to GI because they're more alarming. So I kind of split them up into upper versus lower GI symptoms. So upper GI symptoms could include vomiting, throwing up blood, which is hematemesis, refractory reflux, meaning you've tried medications and the patient's still having a lot of symptoms, dysphagia, which is trouble swallowing, or odynophagia, painful swallowing, and abdominal pain. And you'll see here that abdominal pain is also listed under lower GI symptoms because it can be in different areas. Other lower GI symptoms that are red flag symptoms include blood in the stool, which could mean that there's red blood or there's black tarry stool. And I should mention here that blood tends to act as a laxative. So if the patient is having bleeding from higher up in the GI tract, the stool may turn black. But there are other things that can cause black stool, such as certain over-the-counter medicines like Pepto-Bismol. If the patient's having steatorrhea despite maximizing enzymes, then that could be another reason to refer them to GI. And finally, these are some other conditions where we felt that GI evaluation was warranted. Chronic constipation, which can occur in patients that are pancreas sufficient or insufficient. A history of distal intestinal obstruction syndrome, because you really want to try to prevent further episodes. And then prior to screening, colonoscopy. So I like to meet with patients before they're getting a screening colonoscopy, and we'll discuss later on the recommendations for screening in patients with cystic fibrosis. But basically, I sit down with them, I explain why the procedure is indicated depending on what their age is. I'll discuss the sedation method, and that could depend on what their lung function is, because some patients with a lower lung function or a history of multiple previous procedures may preferably be sedated with anesthesia assistance. And the practice actually does vary across the country. So at my center, we use moderate sedation, which is medications that I prescribe to a nurse who's administering. So we typically will use a narcotic and a benzodiazepine. So, for example, midazolam and fentanyl. But in many places, there's a lot of use of anesthesia assistance, which is typically propofol given through the IV without the patient being put on a breathing tube. In general, we do try to avoid having patients intubated for colonoscopy because I feel that, at least from a pulmonary standpoint, it can definitely set them back. I'll also explain to them how important it is to get an intensive bowel prep, which we'll discuss a little bit later as well. And then determine whether there are any symptoms that may warrant obtaining additional samples at the time of colonoscopy. So we know that cystic fibrosis is actually associated with inflammation in the gut. And occasionally we'll have patients who seem to have some signs of inflammation, whether that's some symptoms or perhaps some abnormal stool testing, like a fecal calprotectin. And in those cases, we may take samples to see if there is any inflammation. And I have had a couple of patients who had, at least on a microscopic level, some colitis. And then finally, there are some cases where it's very important to have a multidisciplinary discussion, including input from the dietitian, the primary CF provider, and other members of the care team. So these are patients that are at high nutrition risk because of their low body mass index or BMI percentile. I think it's really important that the whole team is in agreement with how that patient is going to be managed, and that basically you've tried to evaluate all the options and possibilities for why that patient isn't at an optimal nutrition status. With regards to gastrostomy tube, that is a large step, and so really that does require multidisciplinary discussion with input from all the team members. For my part, as a gastroenterologist, I would discuss, what device options there are for a patient for enteral access, discuss the route of placement, and sedation for placement. So in some centers, we have access to interventional radiology as one mechanism for placement of feeding tubes. So at my center, they are placed by gastroenterologists, surgeons, and radiology. And how you decide on which of these methods to use kind of depends on each patient. It's really an individualized decision, and it may depend partly on their lung function and their ability to tolerate an endoscopy, because in some patients that can be pretty invasive and they may not necessarily tolerate it as well. In terms of removal, this has only recently come to the forefront with me because of some patients who did very well with weight gain on CFTR modulators, and so then this discussion came up about removing their feeding tubes. So in the past couple of months, I've had 2 patients where I did remove the feeding tube, and since in the past the main discussion had been placement, it came as kind of a surprise to me that we were having this discussion, and I think it's quite remarkable that these medications can be so life-changing for individuals that this comes up. But generally, I would only remove the tube after I've discussed extensively with the patient and made sure that everyone on the team is in agreement, including the dietitian and the primary CF provider. Also, the patient has to have demonstrated that their weight has been stable and they haven't needed to use the tube. We generally use at least 3 months. And then I'll also discuss with the patient some of the risks of removal, including the possibility of a gastrocutaneous fistula, meaning that there's a permanent connection between the stomach and the abdominal wall even after the removal. So in some cases, patients who have had a feeding tube in for a very long time can have leaking at that site for quite a while, and occasionally they actually have to undergo surgery for closure. So there are some patients who, even though they're not using the tube for feeding purposes, elect for whatever reason to keep them in, even though they still have to maintain them. So there are patients who want to keep it in for hydration. But generally it needs to be a discussion with the patient, all members of the care team, and everyone should be on board with that decision. So I'm going to switch gears a little bit now. Kim had asked me to talk about small intestinal bacterial overgrowth. So small intestinal bacterial overgrowth, or SIBO, is characterized by an abnormal bacterial colonization in the upper GI tract. It's estimated to affect 30 to 40% of people with CF, so it's actually quite common. The symptoms are nonspecific, so those can include abdominal pain, bloating, gas, weight loss, and nutrient malabsorption. So if you think about it, these symptoms really can be confused for pancreatic insufficiency. The challenge here, especially in patients with CF, is that the diagnosis can be very difficult. So traditionally, we would do an endoscopy using a longer scope and actually suction some contents from the small bowel, typically from the jejunum, and send them off to see whether anything was growing. And honestly, I think I may have done that once in my training, and I'm dating myself, but I finished my fellowship in 2009. And I'm not aware of, I can think of one procedure offhand that I heard about somebody doing. The problem is it's rather invasive, and at least in kids they may require quite deep types of anesthesia. So we don't typically do that anymore. Breath testing is another method. So this involves the patient ingesting lactulose or glucose, and then they measure exhaled gases, predominantly methane and hydrogen, that are produced by bacterial fermentation. The problem with the breath testing in patients with CF is that they're oftentimes on antibiotics, which can affect the results. Other things that can affect the results and make it hard to interpret include previous abdominal surgery or delayed intestinal transit. So in reality, in patients with CF, it is rather challenging to make the diagnosis. So what do? Well, this is an algorithm that was suggested in a review article a few years ago from a supplement of Journal of Cystic Fibrosis. So if you have clinical symptoms and history that are suggestive of SIBO, first off, you want to make sure that there are no red flag symptoms, because if there are, you should consider other diagnoses. If there aren't, then they recommend an empiric treatment with 14 days of antibiotics or polyethylene glycol. The use of polyethylene glycol 3350 or PEG, which is also oftentimes called Miralax, is kind of based, though, on some small series of patients who actually had a reduction in the likelihood of a positive breath test after treatment with PEG. So I was kind of surprised when I saw this in their algorithm. The antibiotics that are used are listed in the table on the right. I would say that there are some data in patients that don't necessarily have cystic fibrosis, but in the literature on SIBO, that if they're predominantly methane producers, that treatment with a combination of rifaximin and neomycin may actually work better. However, neomycin has a lot of potential toxicity, or it may have drug interactions. So if the symptoms are not improved after the empiric treatment with antibiotics or PEG, then you need to consider that something else may be going on. If they are improved, some people end up repeating courses, alternating with days off to see if that helps the patient. Or if they treat it initially with PEG, you can continue that.
Okay, so now I'm going to talk a little bit about nutrition management in terms of SIBO. So again, like Linda said, the symptoms are very similar to malabsorption. So abdominal pain, bloating, diarrhea, and steatorrhea. So if you have a person with CF that has these symptoms, you really need to consider SIBO as a potential diagnosis if you change enzymes or make adjustments to their enzyme regimen and you're not noticing any improvement. You need to kind of keep SIBO on your radar in terms of what is going on with your patient. And people with CF have multiple risk factors for developing SIBO, hence the 30 to 40% of patients with it. They have decreased bicarbonate secretion, they have increased transit time, they have frequent antibiotic use, PPI use, and altered gut microbiome, all contributing to the potential for SIBO. And then research does show that there is a decrease in the types of bacteria generally regarded as markers of a healthy gut microbiota in persons with CF. So I'm going to say it wrong, but Faecalibacterium and Bifidobacterium are decreased. And then antibiotics and a high-fat diet are shown to increase the ratio of bacteria that are associated with a less healthy gut microbiota. And then the dysbiosis of the gut does affect systems that are not only gut related. So it can affect kidney stone formation, and the CF gut microbiome diversity is also correlated with FEV1 percent predicted. So predicted FEV1 decreases as that decreases, the microbiome diversity decreases. So it's kind of keeping that in mind as well. So there is a lot of correlation in terms of the gut microbiome and other symptoms throughout the body.
So we're going to switch gears now and talk about acute pancreatitis. So this is data from the CF Foundation Patient Registry, and I've highlighted the row showing the incidence of pancreatitis. So the centers will report whether the patient had pancreatitis within the past year, and as you can see in both adults and kids, the rate is very low, overall 1%. So acute pancreatitis, we feel that it may affect only those patients that are considered pancreas sufficient, meaning that they were born with at least 2% of residual pancreatic function, and they're able to digest and absorb nutrients without enzyme therapy. Based on the registry, we think that about 15% of CF patients were born pancreas sufficient. And that's important because they actually have to have sufficient pancreatic acinar tissue in order for them to have ductal obstruction to cause pancreatitis. It likely occurs mostly in milder phenotype patients. So at least before the era of newborn screening, some of these older publications showed that patients with pancreatitis were generally diagnosed at an older age, and they had a lower sweat chloride. Overall, there's about a 20% lifetime risk of developing pancreatitis among patients with cystic fibrosis who are pancreas sufficient. And there are certain environmental or genetic factors that could modify the risk. We know that both alcohol and tobacco use actually impair CFTR function, so those can contribute to the development of acute pancreatitis. Also, there could be hypertriglyceridemia or some other mutation that can affect the risk of acute pancreatitis. So this next slide, this graph is a kind of a schematic showing a model of how different factors may contribute to pancreatitis. So the development of pancreatitis is associated with the opposing factors of the severity of ductal obstruction, which is shown by that dotted line, and the degree of pancreatic acinar reserve, which is shown by the solid line going up, kind of sloping upwards to the right and then plateauing. If you look, though, in the lower left of the figure where you have the double-headed arrow and it says PI, basically, if the patient is pancreas insufficient, they don't have enough pancreatic acinar reserve to even develop pancreatitis. So in terms of the natural history, this has been looked at previously. It appears that about 60% of patients who have episodes of pancreatitis have multiple episodes. So they have what's called recurrent acute pancreatitis. In blue, 20% have just a single episode, and 20% progress to chronic pancreatitis. And I just want to emphasize, this is among the patients who are at risk for pancreatitis, so they're pancreas sufficient. So the big question now is what happens with CFTR modulators? So that, I think, is kind of a gray box in an area that we're still a little bit unclear on, and it's a little challenging to kind of wrap your brain trying to understand all of the evidence that's coming in, but there's still a lot of questions. So certainly, if you give someone who's pancreas insufficient a modulator, they can actually become pancreas sufficient. And one of the posters that was presented in a rapid fire poster session yesterday was reporting a case series of kids, and they had 4 patients who developed an elastase that was greater than 200 after treatment with modulators. However, we have heard that some of these patients then go on to have an increased risk of pancreatitis. So there was a previous case report of a patient who became sufficient, and it was only recognized after the patient had acute pancreatitis. On the other hand, there's been a case series from Johns Hopkins which showed 15 patients with a mean 37 months of follow-up who had a history of at least one episode of acute pancreatitis, and they were given a modulator, and none of these patients developed acute pancreatitis, after being initiated on the modulator. And I should mention there was a recent study by Ramsey et al. Using insurance claims data. And this data showed that the use of modulators may actually decrease the risk of hospitalizations due to acute pancreatitis in both pancreas-sufficient and insufficient patients. I think this was an interesting study. It did use prescriptions for enzyme therapy to determine who is pancreas-sufficient or insufficient. So it was a little limited in the sense that they didn't have access to medical records, but I think it does generate some hypotheses. Kim is going to talk about the nutrition management.
Okay, so, during a flare of pancreatitis, you want to avoid foods that cause discomfort. A low-fat diet is not necessarily indicated. You just want to avoid foods that cause that specific patient any discomfort. And then hydration is really important. You want to make sure that the patient does stay hydrated, so making sure that they are drinking, and hopefully that is something that they can tolerate. And then between flares, every person should be following a regular diet, no restrictions, other than avoiding alcohol, obviously. And are enzymes required? Not necessarily. Enzymes are not indicated unless they have an abnormal fecal elastase that is checked with a formed stool between flares. You do not want to check a fecal elastase during a pancreatitis flare, and you do not want to check it with a stool that is not formed, because it will cause a falsely low fecal elastase. And the other thing is stress can lead to a pancreatitis flare. Obviously, not nutrition specific, but you really want to try and help your patients reduce their stress, whether it's through meditation or anything. So any way that they can avoid or decrease their stress is going to help. And then the other thing is the patient needs to be educated. So for pancreatic sufficient patients, they need to be aware of what the symptoms are for acute pancreatitis. So abdominal pain, nausea, vomiting, diarrhea, and they need to be their own advocate. So if they're going to an ER or seeing a physician that's not where their CF center is, they need to be able to advocate for themselves, because that physician may not be familiar with CF and that they are at higher risk for pancreatitis with pancreatic sufficient CF. So if that's not on that physician's radar, they need to keep it on their radar and speak to the physician and say, hey, we're concerned that this might be pancreatitis. So it's really important for the patients or the parents to be their own advocate, because it's not always the case.
Turn it back over to you. Oh.
I was just going to take the question.
Oh, yeah, sure.
So we have a question. Is this on?
Yeah.
This person says, we have a few patients who are pancreas insufficient, yet have chronic pancreatitis with acute flares. Have you seen this, and do you have any thoughts on treatment? So I think that's a little challenging. Patients who are pancreas insufficient, I guess I would kind of want to know more about the patient, because it's kind of an unusual situation. So if the person who raised the question doesn't mind giving a little more information, I would want to know, how is the diagnosis of an acute flare of pancreatitis being made? Because a lot of times, at least patients who have pancreas insufficiency, you'll see on their imaging their pancreas has a lot of fat replacement. There's just not a lot of tissue left. And so if you're trying to go by kind of the hallmark ways we diagnose it, so you have to have 2 of 3 criteria. So abdominal pain, a lipase level at least 3 times upper limit of normal, and imaging. So in someone who has chronic pancreatitis, if in someone who has pancreas insufficiency, a lot of times that enzyme level is not going to be particularly high. So it's difficult to go by that. CF patients may have a number of reasons to have abdominal pain, and then I guess you could make the diagnosis via imaging. So I would feel it was more reliable if it were made by imaging with the appropriate history. So is that what you're referring to?
So is a patient with frequent hospitalizations for abdominal pain, full GI workup, and finally our pancreatic specialist is the one who gave her the diagnosis of chronic pancreatitis with 2 layers. She comes in about every 3 to 4 weeks.
Yeah, that's really challenging. I mean, there are certain medications one can kind of try for pain. I mean, this might be the type of case where you would consider a modulator. Is the patient qualified? Okay.
And we did a trial off of Trikafta to see if Trikafta was making it worse.
Oh.
It did not make it worse, it just made her lung function worse, so we put her back on Trikafta.
How long was she on the Trikafta before you took her off?
She had been on for over a year.
Hmm. Well, I think if the patient has had a full GI evaluation, they probably have had dedicated pancreatic imaging with an MRI, MRCP. So I guess if secretin were given for that to make sure there's no anatomic abnormality, then that it sounds like that's already been done. So yeah, I mean, I hate to say it, but you also want to make sure that the patient isn't having any lifestyle measures that could be contributing. So it's important to try to ask about any drinking history or smoking, because those can also contribute. Not to say that that's what's going on in this case, but I think that's a very challenging situation. Is the patient seeing a specialist who's more knowledgeable about CF and GI, or?
Yes, she's seen our CFGI physician and our pancreatic specialist. She went to another institution for a second opinion and didn't get anywhere. They had nothing else to add either.
This could be anecdotal, but I mean, I think it's possible that if someone is getting dehydrated, I mean, one thought would be to try to make sure the patient's drinking plenty of water, but it sounds like you've gone through many measures and she's still. Yeah, I mean, that whole discussion of whether someone should have surgery for this kind of thing is really difficult, especially if the patient has impaired lung function, I mean, that's a huge surgery to take out someone's pancreas. So I think it becomes a discussion, and it's very individualized as to whether that's something that should be done. So we're going to switch gears now and talk about constipation and distal intestinal obstruction syndrome. And Kim and I were joking that we're not really sure if people call it DIOS or DIOS, but I'm used to calling it DIOS, so that's what you hear from me. And Kim's going to call it DIOS, and it's just going to be fine. So in terms of constipation, it's really kind of based on symptoms. The symptoms can include things that aren't necessarily asked about unless you elicit the history. So difficulty passing the stool, straining. What is the stool shaped like? Is it hard or lumpy? Does the patient take a really long time to use the restroom? They may have a poor appetite. They may have flatulence or abdominal discomfort. Obviously, that can be a little challenging in somebody with cystic fibrosis because they may have multiple reasons to have abdominal pain or flatulence. Examination may reveal a palpable fecal mass, and I believe that this was primarily written by pediatricians because I hate to say it, but in adult GI training, we just don't get that natural feel for whether you can sense that there's a big wad of stool or not. And I think it's a pediatric training, but also I think in general, most of the patients I see during training don't have CF, and they may have a high BMI, and it just may be difficult to palpate. Imaging for constipation is not usually warranted unless there's concern for obstruction. In terms of DIOS, there was a working group from Europe which developed a definition for DIOS. So they had 3 criteria. So first off, there needs to be complete intestinal obstruction, which is typically based on imaging or a history of vomiting of bilious material, a fecal mass in the ileocecum, and abdominal pain or distension. So that's called complete DIOS. And then there's this kind of less severe case called incomplete or impending DIOS. And that generally has a shorter history of abdominal pain or distension. And there's basically no complete obstruction. So of those 3 criteria at the top of the slide, number 1 is not present. So the question becomes, is this patient, do they have constipation or do they have DIOS? In general, the history for constipation will be a much more gradual time course. It will not be nearly as acute. But this is an algorithm that was developed by a task force that was gathered by the CF Foundation a few years ago, and I think it's very useful. So if you see a patient with CF who has abdominal pain and obstipation, which is difficulty passing stool or flatus, the first question you have is, are there any key red flag symptoms? So trouble with bleeding, iron deficiency, anemia, if they've had previous surgery or if they're feeling ill otherwise, so systemically ill, then you need to consider alternative diagnoses. However, if they're not having these key red flag features, then you ask, is this constipation? And these are some of the symptoms that were listed on the previous slide a couple of slides ago. And if so, then you can refer to the constipation treatment algorithm. So this was a separate document and it's available on mycff.org, but basically you can see on the left side they have some suggested steps for management of constipation, which is generally with sorbitol in infants or polyethylene glycol in children and adults. And then you can look at the algorithm there, but what I think is really important is what they actually typed at the bottom, what they called the other considerations. So if step 1, which is the treatment, was unsuccessful, GI referral may be warranted. Avoid opiate use if possible. If they're necessary, then start a concurrent bowel regimen. And then this is really important. Both pancreas insufficient and sufficient patients are at risk for constipation. And finally, there's no evidence to suggest that increased enzymes increases constipation risk. And I actually struggle with this quite a bit in clinic because some patients will come to me and they've basically chronically underdosed their enzymes for many years, and then they come to me and I will comment, well, based on your weight at least, I think your enzyme dose is way below what would be considered a starting dose. And they're very reluctant to increase their enzyme dose. And it's a challenging kind of discussion. I mean, I'm working with one patient in particular, and we made a little bit of progress, and then we just kind of slid back down. So, I mean, you have to just educate patients and hope that they will maybe come to an agreement with you. So in terms of treatment of constipation, they recommended a number of different possibilities, but I've highlighted that sorbitol is the first-line therapy in patients who are less than 6 months, and polyethylene glycol is recommended in patients who are at least 6 months old. So getting back to this algorithm, if you determine that the patient's not having constipation, then you're looking at those criteria from that SBGAM working group, whether this is DIOS or not. So we had a request to show some imaging. This is from a review article from a few years ago, which shows on the left side an abdominal film in somebody with constipation, and the arrows are pointing at stool and gas. So the gas is the darker parts and the stool is the whiter parts. And it's actually distributed throughout the colon. So going all the way from, the colon is shaped kind of like a question mark, so going all the way from the left side all the way down to the right side. On the right side of the screen, you see a CT scan image of a patient who has DIOS. And what you can see on the left, lower left of there, it says decompressed cecum. So basically the cecum is the very most proximal part of the colon, so closest to the end of the small intestine. And normally, the cecum should be much larger than that. In fact, if you think about it, the large intestine has a larger diameter than the small intestine. But in this patient, because of the obstruction, you could see kind of in the center of the image that they're highlighting some what are called fecalized contents in the small intestine. So it basically looks just like stool. And you can see that the diameter of that area is actually larger than the cecum. So in terms of treatment for DOS, they had algorithms for both outpatient and inpatient treatment. So the first question is it feasible to treat this patient as an outpatient? So that can depend on a number of characteristics. So they had some suggestions here that, and I think my favorite one that I don't think a lot of people may necessarily consider is stable home situation, how much that might contribute to the ability to manage this patient as an outpatient. So then the further management really depends on whether the patient has milder symptoms or more severe symptoms, and that's going to dictate how aggressive you're going to be with the treatment. So for milder symptoms, patients can be treated with less aggressive doses of polyethylene glycol, but if they have more severe symptoms or if they're better able to tolerate large volumes, you can give it more quickly. Then you need to assess for whether or not the symptoms have resolved. And if they have, then you basically want to get the patient on a regimen so that they don't have this happen again. If they haven't resolved, then basically they recommend referral to the emergency department and proceeding to their other algorithm, which is for treatment of suspected severe DOS. So with this, basically, they recommend obtaining imaging, and I really want to stress here something that people who aren't in GI don't necessarily know. So basically, the imaging, if you're concerned about obstruction, so obstruction is the first of those three criteria I mentioned for the diagnosis of DOS. So if you just order abdominal film, at least in my hospital, it'll be listed as KUB, which is short for kidney, ureters, bladder, and that's a supine film. But if your main question is there obstruction here, that's not going to be sufficient to look for obstruction. So you really need to get an upright film. In adults, oftentimes it ends up being a CT scan of the abdomen and pelvis. You need to initiate supportive care for bowel obstruction. So these patients need to be on bowel rest, they need to be hydrated, and you need to control their nausea. And then obtain a GI consultation. So the next step in the management really depends on whether there are peritoneal signs on exam. So is there any guarding? And if there is, then you should call the surgeons for consideration for surgery. I mean, really, we don't like to go to that step because of all of the morbidity associated with surgery for DOS. But also, just to prepare, you want to make sure that this patient, if they really did end up requiring surgery, is medically optimized from a pulmonary standpoint and ideally from a nutrition standpoint, although in this case it's a little challenging. So I mentioned something about air fluid levels. So if there are no peritoneal signs, you want to investigate whether or not there are air fluid levels on imaging. And if there are, then the patient should get an NG tube placed for decompression and then undergo a therapeutic radiopaque contrast enema. Typically, this is something like gastrographin. And basically, you need to ensure that the contrast actually refluxes up into the terminal ileum. So in our own center, we've struggled with some of the radiologists not quite understanding the need for that contrast to reflux up into the terminal ileum. So I think we're going to need to sit down with them and kind of educate them about why that's important, because that's really where the obstruction typically is. So you really want to make sure that they understand that and that they're not stopping when the contrast gets to the right side of the colon. Also, the patient can be given polyethylene glycol through the NG tube. If there are no air fluid levels on imaging, then you can proceed with fecal disimpaction with saline enemas, polyethylene glycol solution, and this may or may not be given through the NG tube depending on how the patient is doing. And then you can consider a therapeutic radiopaque contrast enema. So basically, you need to confirm that there's been some clinical response with repeat imaging, and obviously you also need to be monitoring the patient. Are they having a return to bowel function or not? Because if they're not, you can go through an algorithm and try treating them some more, but at the end of the day, you have to decide, is this really DIOS or not? And if it's not, maybe there is something else going on. So their algorithm is actually much bigger than this, and I just kind of provided the highlights here, but you can go to mycff.org and download the whole thing. It's just very difficult to print out, so I try to kind of break it down and make it a little bit simpler.
I do have a question.
Oh, okay.
So there is a question. It's going back to, I think, the SIBO part of the talk. And it's how often, it's for us and any other clinicians in the room, it's how often, if at all, do CF patient care teams test for microbes in the large intestine, either via stool or colonoscopy? So I will tell you, I don't know. I don't think that it's tested at all, except for if we're looking for C. diff, if that's what you're asking. I don't know. It was asked how often, if at all, do CF care teams check for microbes in the large intestine, either via stool or colonoscopy? And my thought is, I don't think at all, unless we're looking for C. diff. And we do that only if we have a concern specifically for C. diff based on symptoms and antibiotic use. So I don't know any other reason we would do that.
I would say that if there's a concern for an acute infection, that's typically when we would send stool to look for C. diff or other pathogens. And then you have to consider, is this patient immunocompromised or not? So some of our patients have had transplants, so they're on immunosuppressive medications, and then, in my opinion, the suspicion for some infectious cause that's not been addressed will go up, and so I may be more likely to check for an infection. During colonoscopy, I would say typically I don't collect stool for testing. Rarely we will, not necessarily a patient with CF, but if, for example, somebody's in the hospital, and I don't know why it's so difficult to get stool studies on an inpatient. They're a captive audience. They're there. They have their container, and yet somehow you put the orders in, and the stool sample never makes it to the lab. So there have been occasions when I'll have to basically explain to the technicians, you remember those old traps we used to have to collect polyps? They had to find these old specimen containers we used to use, and we collect some stool. But the problem with collecting during colonoscopy is a lot of the modalities we use to try to maximize patient comfort include putting a lot of water in during insertion. So as you're going into the colon, you may use water to lavage and just try to reduce discomfort. And so I feel, if you've put a lot of water in there, you're going to get kind of garbage data because your stool will be diluted. So, I have to try to be aware of the possibility we may want to collect stool and then not put a lot of water in because I don't want to affect the results.
There's actually there's a lot of questions. So I'm just going to go down the list before I go back to speaking. There's a question on how common is SIBO in pediatric patients with CF and what sequelae exists if it's never diagnosed. I don't know if it's specific, if there's specific information on whether it's adult or peds, so I don't know how common it is in peds versus adults. And I don't know, really it's the symptom management and quality of life for the patient on whether it's diagnosed or not. The patient usually has symptoms with SIBO, so I think that it's more how is the patient going to do if it's never diagnosed or never treated, in my opinion. I don't know.
Yeah, I'm sorry I can't speak to the prevalence of SIBO in kids. I don't treat kids.
And then,
I think she has a question.
Oh.
Yes, I'm sorry, they don't seem to have.
So I think the problem is maybe the diagnosis is because an adult will have a thing about bloating and other things, but you actually don't really get that. I think now the UK needs to make sure we ask this question about what things is okay.
I think that's why I really encourage for the teams and the dietitian and the pediatric centers to use the symptom tracker, even if they're talking to the parent. Like, the parent can get a little bit more information from their child, or they know a little bit more about their bowel habits, or if they're complaining of abdominal pain. So I think it just pulls more information out than if you say, hey, you having any abdominal pain, bloating, diarrhea, greasy stools. Sometimes they'll just be like, no, everything's fine. Whereas the symptom tracker really pulls out a lot of detail and will really get to the nitty gritty of their GI symptoms. So I think that that's something that can really be helpful in a pediatric or adult CF center for the dietitian to use in their regular visits. So the next question is for me. It says, could pancreatic enzymes help during a flare, since EPI can be transient for those with acute pancreatitis? So I've thought that as well, but there's actually no evidence for it. So I can't say yes or no. Do you have any
I'm
thoughts?
sorry, I didn't quite catch the question. For some reason, it's not showing up here.
Yeah, I was using mine. It says, could pancreatic enzymes help during a flare, since EPI can be transient for those with acute pancreatitis?
I mean, I believe there's some older, not very strong data to the use of enzymes for pain, but in terms of making the episode any shorter, I'm not aware of that. And in reality, I don't feel like anecdotally it seems to help that much. So I don't generally prescribe enzymes for a flare.
Okay.
There are a lot of questions.
Yeah. So I was just,
How do we get rid of them?
we can mark them as answered on there.
Okay.
So the next one is, do you recommend retesting fecal elastase for kids who may have lowered enzymes themselves and seem to be growing okay? So in my adult center, if someone has either stopped or decreased their enzymes, well, really stopped them. If they lowered their enzyme by 1 and are feeling okay, no symptoms, I'm not gonna be upset about it. But if they've stopped their enzymes and they feel like they're not having symptoms, we tell them if they want to stop their enzymes, they need to recheck their fecal elastase, because there's no evidence that as an adult, the Trikafta will change them from pancreatic insufficient to sufficient. I know that we're talking about that there are case studies where that has happened, but if that's the case, then we need to have them as that case study. So either they will at that point say, well, I'll restart my enzymes, or we send them home with a fecal elastase testing kit to do their fecal elastase. So.
I'm sorry, I was kind of mystified by the app, to be honest. So I would say there was a paper a few years ago, because we had this discussion at my center about the elastase testing, and it did suggest that you could check elastase even with a flare, that it wouldn't be affected that much. The results wouldn't be affected that much by a flare. So, I mean, I don't know if that's what you were talking about just now.
No, if you recheck it, if they stop their enzymes or lower their enzymes.
Oh, okay.
But yeah,
No.
I do. So this is going to be for you. We have a drug-seeking adult who presents to the ED with dios every 2 to 3 weeks. Only sometimes is actually backed up. Should we really be getting 2 to 6 abdominal x-rays per month to check every time?
I don't see this here. This is so weird. You may read it on here.
Yeah.
A drug-seeking adult. We have a drug-seeking adult who presents to the ED with DOS every 2 to 3 weeks, only sometimes is actually backed up. Oh, well, I certainly wouldn't like the patient to get a CAT scan every single time. The level of radiation from an X-ray is much lower. So an abdominal pelvic CT is like 200 to 300 X-rays. So if you put it in that perspective, I mean, I think it's okay. It's really challenging because you kind of want to determine, is the patient obstructed or not? Or do they have some ulterior motive to going there? So, I mean, I guess it would be an even harder question if this was a child, because then you're subjecting a child to all these X-rays. But I probably would still, because if it came down to some problem where there was a bad outcome and the patient wanted to, God forbid that they wanted to sue, I mean, it's going to be your word against theirs. And you could see someone saying, well, but why didn't you get any imaging? You know, so unfortunately, I think you kind of are put in a spot where you kind of have to give them the benefit of the doubt and get the imaging.
So I changed it to the unanswered.
Oh, it's because it's in the discussion, that's why.
Oh, no, that's not. It's in the questions. So the next one is, would you recommend having the patient fill out the GI tracker on their own, or is it appropriate to go through it with them? So I prefer to have them fill it out on their own, but if necessary, I will go through it with them. But I think it's good for them to go through it on their own, and that way maybe they'll answer more honestly. Terry, any thoughts on that? Do you have to go through it with them? Yeah, I go through it with them afterwards as well, but I think that it's good for them to answer the questions on their own. But I'm sure that you could do it either way. I agree.
We only have 10 minutes.
Oh, okay.
Do you think we should?
Yeah, we're going to finish the talk and then we'll continue going through the questions so we can make sure that we finish everything. Okay, so for nutrition management of DIOS, so obviously DIOS is not really nutrition specific, but really you want to focus on the prevention. So enzyme adherence is really the most important thing. DIOS is associated with CFTR dysfunction and the dehydrated luminal contents, but it can also be caused by poorly absorbed fat, which is proven by the correlation between DIOS and enzyme non-adherence. So that is really the most important thing that you can do, is make sure you're educating your patients on adhering to their enzyme regimen. And then the other thing is hydration. If they're not hydrated, then all their gut contents are going to be even less hydrated. So that's going to make it even more likely that they will end up with DIOS. And then it's important for patients to know their risk. If they've had a prior episode of DIOS, they're more likely to have it again. If they had a history of meconium ileus, they're more likely to develop DIOS. If they are pancreatic insufficient, they are more likely to develop, they're likely to develop DIOS. If they are using any narcotics or they've been put on narcotics, they are more likely to develop DIOS. And typically, like when you're differentiating between DIOS and constipation, it's typically a more sudden onset than constipation in terms of the abdominal discomfort and the pain. And typically it's more in their right lower quadrant versus where constipation usually is causing discomfort. And then you want to provide anticipatory guidance. You want to make sure that their DIOS is being addressed properly if they're not being seen by a CF-specific provider. And I saw that this was a comment that was put in the questions as well. They need to, again, advocate for themselves. They need to know that this is a concern for them and that they need to request the things that they need, because they may have an obstruction and not just constipation. So that they're not being sent home just because it may be constipation, and that this is a big risk for them. And then constipation, again, because we kind of go hand in hand. Constipation, whereas DIOS is really common in pancreatic insufficient, as Linda said, constipation is common in both pancreatic insufficient and pancreatic sufficient patients. And again, is still common and associated with lower fat absorption. And that really contradicts that idea that, a lot of people, especially patients, have that increasing PERT causes constipation. And again, hydration is essential. If you're not hydrated, if this is true for CF as well as the general population, if you're not hydrated, you are more likely to develop constipation, whether it's just fluid or fluid and electrolytes. And then constipation is going to lead to poor appetite and poor intake, because if you are not moving anything through, you're just not going to feel hungry because nothing is going anywhere. And then abdominal pain. It may be generalized, but it also may be, again, I said, dios is on the right lower quadrant. Constipation is typically the left lower quadrant, because they're developing in different locations, because you're backing up on the left from the cecum, and dios is on the end of the ileum to the colon. So gas and bloating are typical symptoms. And again, whereas dios is a really more sudden onset typically, constipation is a typical gradual onset. So pass it on to Linda to talk about the cancer screening.
So in the interest of time, I'm just going to go pretty quickly through these slides. So we know that cystic fibrosis is linked to a higher risk of colorectal cancer, and this is based on data from the CF Foundation Patient Registry, which was comparing the risk of colon cancer to the kind of average Americans of the same age range, like the SEER incidence of colon cancer. And they found that using the registry data, that the risk of colon cancer was 6 times higher than expected in patients with cystic fibrosis. And the risk seemed to be increased in those with more severe cystic fibrosis. We know from some other studies, particularly from the University of Minnesota, that colon polyps, which are thought to be the predominant precursors to colon cancer, seem to be more common in people with cystic fibrosis. And so this led to the development of colorectal cancer screening recommendations a few years ago. So in 2018, this was a publication in Gastroenterology, which is a journal of the American Gastroenterological Association. They developed a task force between the AGA and the Cystic Fibrosis Foundation, which included various stakeholders, including, I believe there was some patient input, as well as a pulmonologist, a statistician, and other members of patient care teams. And they basically had to have agreement among some different ideas that were discussed. And they did a literature review to kind of look over all of the data that was known about the risk of colon cancer. And they actually hired some statisticians to do modeling to try to determine when should a patient start screening. So that's what these recommendations are based upon. They did have 10 points in their recommendations, and I tried to distill it down to 6. So basically, it should be a shared decision-making process with consideration of the patient's overall treatment goals and their other medical problems, the safety of the procedure, and that's where kind of what their lung function gets into that decision, and then their quality of life. There's not currently enough evidence for other tests other than colonoscopy, so stool-based testing is being evaluated in this upcoming NACFC study, which is sponsored by the CF Foundation. They recommend starting screening at age 40. So recently, the guidelines for screening of Americans that were at average risk, meaning no family history, was lowered to 45. So this is 5 years younger than that. And then they should have colonoscopy every 5 years if no polyps are found. And that is assuming that the bowel prep was adequate. In transplant patients who are on immunosuppression, they recommend starting at age 30 or within 2 years of transplant, and then every 5 years if no polyps are found. If polyps are found on colonoscopy, then a patient should have a repeat colonoscopy in 3 years, and that's for both transplant and non-transplant patients. But the interval may be shortened if a lot of polyps are found, or if, for example, the prep wasn't sufficient. So really, an intensive bowel prep is needed because these patients have malabsorption and they tend to have constipation. It's especially important to examine the right side of the colon when they were looking at the data from the CF Foundation Patient Registry, they had to contact all the centers and get information regarding where these colon cancers were located. And basically, they felt that a lot of them were located on the right side. And actually, in my experience, I've found that a few of my patients had polyps in the terminal ileum. So now I make it a practice to look in the terminal ileum. That's not in the recommendations, but that's just one of the things that I've added. And I should say that in my practice, it seems that pancreas deficient patients seem to need less prep, but I'm a little concerned about relaxing it too much for everybody. So basically, when I meet with a patient and I talk with them, I go kind of on a case-by-case basis. I think, some of these patients tend to be have much less severe pulmonary symptoms, and might be able to get by with a little bit less prep, but generally I don't want to push it. So this is the bowel prep that was published from a publication, one of the earlier publications from University of Minnesota, and it was also referenced in the colorectal cancer screening recommendations, and this is just taken from the University of Minnesota. So we use this prep at our center as well. We used to use Miralax with Gatorade, but I felt that first off, that's an off-label use, and it's not isoosmotic. But generally, since we've switched to these prep instructions, I feel like the preps have generally been better. But what you can see basically is that the patients have to start their prep 2 days before the procedure, and it includes some magnesium citrate, which unfortunately right now is kind of difficult to obtain due to a supply shortage. And then there's bisacodyl, as well as a polyethylene glycol with electrolytes-based prep. But basically, the amount of prep they're taking is 1.5 to 2 times that a patient without CF would be taking. And then the part that says the day of the procedure, so you can see here, at least at Minnesota, they recommend having an afternoon procedure, and this is what's called split dosing. So the patient actually takes some of the prep the day of the procedure. We found in studies, not in CF patients, that splitting the dose like this actually with multiple washes provides a superior prep. But they need to stop in these instructions 4 hours prior to procedure to allow for safe sedation.
Okay, so for colorectal cancers, in terms of the dietitian, you want to make sure your patient is aware of any symptoms that they might have in terms of colorectal cancer. So any unexplained anemia, change in their bowel habits, blood in their stool, unexplained weight loss, and then knowing that immunocompromised patients are at a higher risk. And then dietitians can be a critical resource for educating patients on the screening colonoscopy. And it's important for someone in your CF care team. It can be the dietitian, it doesn't need to be the dietitian, but making sure that the patients are getting their screening colonoscopy when they are due for it. And then some other considerations that you want to keep in mind are modulator dosing. Patients are going to be on a clear liquid diet, or especially NPO at the day of their colonoscopy. Can they take their modulator? In my practice, I would say no, take it after your colonoscopy when you can take it with a fat-containing food. As long as your doses are at least 6 hours apart, not that you want to do that on a regular basis, but you don't want to take your modulator without a fat-containing food. You will not get the full benefit of the modulator. And then if you have CF-related diabetes or reactive hypoglycemia, you want to make sure that your patient is aware of this and the doctor doing the colonoscopy is aware of it, and that way it can be addressed. And then some additional questions and areas to talk about. So we talked about some enteral tube management. So at least an annual appointment with GI. I would say in adults, I typically end up managing their enteral feeds. We don't always get the opportunity for our patients to see GI regularly, but I know in peds it's a lot more common for them to see GI more regularly. And then when you're partnering with your patients, you want to make sure that you know how do they prefer to communicate with you. Do they want to communicate with you by phone? Do they want to do a telehealth visit? Do they want to communicate with you by Epic messaging or email, or do they want to text you? I have a lot of patients that have my cell phone number and they'll text me when they have a question. As long as they don't abuse it, I'm fine with that. So.
There's so many questions and answers.
I know. So we have a lot of questions that we'll try and get to. And then Jess Leonard was supposed to be here, but she got sick, but she did plan like the setup of the session, so we want to thank her.
And of course, we want to thank the planning committee for inviting us to talk.